welcome back to another episode. Great to see you again, Renee. How are things going?
It's going so good. How are you?
We're coming off a spring break, so I always love the little bit of rest and rejuvenation after getting away for a little bit.
Yeah, I like it because I have less people in the office during spring break. And so lots of folks took the advantage of the time off with their kids from school and got out of town and makes it just a little bit calmer and easier around. I didn't get to go anywhere this year myself, but it's still a little bit of a break because you have a little bit less going on all around. It's a little slower sometimes during the break. It's awesome.
Absolutely. And now's the recovery phase, right? You get back from a great trip. And in my case, it's Jennifer, my wife, now complaining about the sand that's left in the bottom of the suitcases and all over the house. And so, that's just one of the consequences that we have to deal with. So I love having that problem.
Tough consequence to have sand along the Midwest. What are we going to do? So today we're going to be talking about the overview of crisis services. And we're going to try to do something that's kind of hard to do, but we're going to talk about, like, from that big picture, what really should it look like? There's a lot of links today in the show notes if you want to know what we're talking about, because there really is an array of services that when somebody's in a crisis, whether it's mental health crisis or just a general crisis, something has gone awry and they need a place to stay for a night. We will talk about lots of different ways you could get into crisis. Crisis isn't just suicidal. It could be lots of things. And then there's a whole array of services that we can meet people where they are is the goal. And we're going to talk about what that looks like today. So Jason, when you start thinking about an array of services for crisis services, what are those services you think about?
Yeah, well, let's start with what an ideal system looks like. And Renee, this is a topic I love to talk about. When I was going to grad school, I worked at a 24-hour crisis response entity. I was part of the 24-hour call center. I was a supervisor there. I triaged calls that came in, coordinated responses with local law enforcement. And so I hate to admit it, but that was nearly 2 decades ago that I was part of a system where we were making a difference and doing this. And although it was just one county, the third largest county in Pennsylvania, the concepts and the ideas we're building upon today nationwide are nothing new,
Mm-mm.
right? There's a lot of science behind this. There's a lot of research behind this. And it's only been, in the last couple of years, and especially this past year with 988 being implemented across the country, where we really started to talk about how do we create a consistent continuum of crisis services, no matter where you live, no matter what state you're in. And how do we do that in a way that makes a difference? And I think that the challenge over the years has been it's just been so disorganized in how the system has been built and created. And we've seen that as we travel around the Midwest of just how the system is fragmented and not working together. So, I was gonna say, well, let's start with, what does a good crisis system look like? And we all know it starts with the call center, right? It starts
Right.
with that first call for help, and that's 988, right? And sometimes it's 911, and so we need to think about where do those calls go? The next step is it's a response. There has to be a mobile response
Yep.
by someone who can support the individual no matter what their crisis is, right? And crisis should be whatever the person defines as their crisis.
Okay.
Generally, it's an emotional crisis. It could be a substance use related crisis, but thinking about what is that crisis? And then
Mhm.
next, you need someplace to go, right? Sometimes you need to go somewhere. It could be a hospital. It could be a crisis stabilization program, but there should be an array of places to go that are safe for someone if they can't continue and to remain in their home,
Right.
right? And then we think about, the fourth kind of thing. We always talk about the three-legged stool. I know, Renee, but I'm adding a fourth, and that is thinking about the principles and practices and how do we implement best practice and cultural competence and being linguistically appropriate so that we're serving everyone equitably.
Yeah. And I know one of the things about a crisis continuum that's most frustrating for people in crisis is when it's done poorly, they have to repeat the story at every single juncture. And if I had to put my finger on one thing that is the biggest complaint of somebody who's in crisis is that it starts over and it starts over and it starts over. And if it's a traumatic experience, something that caused them to feel like they were in crisis, so, something that was emotionally challenging for them, to have to just repeat it and repeat it and repeat it and repeat it because we don't do a good job of that warm handoff and handing it off to the next case really doesn't make the system better. And unfortunately, we hear that pretty commonly about, I called the number and then they send out mobile response, but then I had to tell them all over again. And then they took me to, an access center to get an evaluation and I had to tell them to them all over again. And then once they decided they were going to send me to wherever for my stay or whatever they're going to do with me, then I had to tell them all over again. And so, you still have some real, like you said, some real big bumps in the road. My first involvement with crisis was probably even longer ago than you. I'm probably thinking in the 3 decades, which is really terrible to think about. But I figured out that I don't work third shift in a really spectacular way. I had a job where I was at the teen youth shelter and I was supposed to do overnight shifts. And my entire job for overnight shifts was to deal with those in crisis that the police or different people would bring in the middle of the night. And my problem was I couldn't stay awake. I clearly am not an overnight type of person. So just have really hilarious memories, not so much of the job, not so much of what I had to do, except at the time when we were back in the days with not a lot of TV channels. This is pre-streaming, people, long time ago. And I basically got to watch QVC all night between that and then some channels that had exercise shows on all night long to have differing types of things to watch throughout the overnight hours because there was nothing on. And then I would do exercise routines at random times at 2 o'clock, 3 o'clock, 4 o'clock, just to stay awake because I'd have to do my 15-minute checks for suicide and whatever. So anyway, I was not really good at this job. So those that are good at it is they're really key quality people out there that are great at this work. But man, I was terrible at it. So when we talk about this, one of the things I think is an improvement of that call center idea, probably changed since you were there, Jason, is and now it's not just call. We also have text and chat. Talk about how that's sort of revolutionized that whole call center idea.
Well, kind of in the story you just shared, you probably lost half the audience when you said TV, and you couldn't control what was on it.
No.
We live in a time where we have to have multiple methods of communication, right? And so I think we've opened the door to engaging other generations who may not be comfortable with using the phone because
Right.
we have a lot of younger people who don't use the phone. My own children don't use the phone. They call and chat and snap and do everything else, right? And so I think that's only, kind of given us more opportunity to communicate even to a greater extent with those folks. I was going to say something going back to kind of what you talked about. One of the things that we did that you don't see happen anymore was more on an advocacy level when we help people as crisis responders. I remember many times that we would sit with the person until they were admitted or until we got them to the right level of care. And that reduced the number of times somebody had to tell their story over and over again. Now, that was also very time consuming because I can tell you that we would do shift changes in emergency departments. And sometimes we would sit with a consumer who is looking for hospitalization for up to 3 days, right? So that would mean a shift change every 8 hours where there would be someone coming in and waiting with that person, supporting that person who is experiencing a mental health crisis, right? And so that we have the same challenges with not enough inpatient beds or misuse of beds, not being able to find the right beds then, because unfortunately we haven't learned anything over the last 2 decades in some areas about how to manage beds, about how to get people to the right level of care. But there are solutions, right? And some of those solutions are more costly, but how do we move people through a system? And so as we think about, we've created more accessibility through chat and text, opening up those phone lines to even a greater audience. But are we doing a better job of responding and connecting? And so as we kind of move our way through this crisis system, let's think about the areas where we can find the most opportunity to do better.
Right. I know someone that used the crisis hotline for as intended, and mobile response responded, and then they got mad that responded. And I was actually pretty excited about the fact that it responded because to you and I, that means it worked, right? To them, it wasn't a good response. It was law enforcement connected and was embarrassing and all the different things. And so the consumer didn't really appreciate how it was done and didn't think it was super helpful. But at the same time, I'm like, but at least it worked. And so, that depends on which side you're on, I suppose. And we can talk more about that. But I know on a previous podcast, we've talked about mobile crisis and how there's all these different types of mobile response and they all look different. And so, it is kind of hard. This can get really into the weeds when you start thinking about the details. But let's just walk through the list of what's supposed to happen. So you kind of did it at that 988 level. You're really supposed to have that call, text, or chat. But in our continuum, we also have what's called warm lines. And warm lines are actual live people to talk to. And so sometimes, I don't know about you, Jason, but I get really sick of, call on the number and press 1 if you want this, and press 2 if you want that, and press 3, or you have to talk to them about, representative to try to get to somebody and all this kind of stuff. And so a warm line, what it is a really great opportunity for somebody with lived experience who has had crises before, like all people have, that is there to talk to you. And so if it's something that you just need some talk to support your situation, and we have peer support specialists that answer those, and that's a great addition in the last few years of something that we didn't always have in a system, because sometimes people just need to bounce something off of somebody, or we've talked about social isolation, they're lonely, they need to be able to talk. And so I know warm lines are another big piece of the puzzle that we really have grown to appreciate.
Well, and even with the crisis call center, most of the time, most calls are resolved just by talking. Only about 3% of the calls even necessitate a mobile response of any kind, right? So, kind of the fallacy is we need mobile crisis all the time. We don't. We only need it for the that very high end, kind of that top part of that triangle. As we think about, what does a mobile call center do? Is they triage, they talk to people, and most of the time they can help work someone through that crisis that they're experiencing at that moment, and then call on to a check-in later on. So, let's just remember that we aren't talking about everyone needs a mobile response, because absolutely everyone doesn't. More times than not, they just need to talk to somebody.
That's right. And that's a really good reason for why it's important that this is a 988 conversation and not just 911. You think of that workload of people that really just needed to talk, that were calling 911 on a regular basis. And 911, as we all really know, if you take a step back as to what it was designed for way back in the good old days, right? It's all about heart attacks and about stroke, and of the physical nature of medical care to get an ambulance to you if something happened. And so over the years, out of sheer necessity, it took on also taking on mental health and taking on other types of crises, but that really wasn't what it was designed for. And so that 911 system, yeah, they've done awesome and they've filled in the gap, but that really, who wasn't, the people mainly were trained in medical, not psychological or counseling. And so the idea of that 988 system was, hey, let's get people put through to people who can deal with these crises and talk people down, just to your point, because 97% of them wouldn't need anything further. When you call 911, there's an automatic response of an ambulance or, whatever other emergency department has to go out. And so those are automatic send outs. And so think of all the call outs that could be prevented if we had a bifurcated system. And so I know sometimes people don't want to talk about that, because some people in law enforcement still want to be in charge of all of it and all those different things. But really, if you look at it from a why this is a good thing, it really can prevent a lot of call outs that were unnecessary.
911 happened within our lifetime.
Yeah.
You realize that, right?
Yeah.
Like, it is really a very recent innovation in the greater scheme of things when we look at communication systems. It's very recent, and it actually took 15 or 20 years to actually finish 911 across the entire country. There were areas in the 90s that still didn't have 911 access, and for 988 to roll out as quickly as it did was really quite amazing. And so when we think about the kind of, we were talking about some of the speed bumps people are experiencing in mobile crisis in 988.
Yeah.
It's really pretty amazing that 988 has been implemented at the speed that it has.
That's true. And the other piece, when you talk to folks that rolled out 911, was just how patchwork the funding was, and there wasn't, dollars consistent across, and that's part of what slowed it down. So the fact that we're still dealing with that with 988, that's not a surprise either. And so you're right. And I think that you were generous, I think, in how long you thought 911 took to roll out. I think it's even longer than that. It was a long time. And so yeah, and then just think how great a job the 988 dispatchers have done to take on all these additional types of crises, when that really wasn't the intent of that system at the beginning at all. So, they really have done a good job. So it's not trying to take away from what they're doing. It's just helping them not have to work as hard on things that's not their expertise, and then bringing in people that do have the right expertise. So it's kind of a win-win, once you shake out through the details about like who's going to do what. But that really is a huge, massive step in the right direction for a crisis continuum. So one of the other levels of care that's on this list is 23-hour observation. So Jason, explain to people, what is 23-hour observation and what's it supposed to do?
Absolutely. And we've heard it called other things depending on, where you go. Sometimes it's called a sit stand, right? And a lot of times, the 23-hour facilities or rooms that we've been into are often connected to another entity. And basically it's just a safe place for someone to go for kind of up to a day, right? It's exactly what it says, 23 hours at a time. It's a safe place that's monitored, that there's someone there to talk to, that you can support someone. And so if someone may not feel safe being at home, they don't need to be in a hospital. They have no friends or relatives where they could go. And so this is a great option to have available in a community just for a safe place for someone for a bit.
Yeah, and the 23 hours, for those that aren't sure why, it's about a billing cycle, right? And so you could be somewhere for 23 hours in a way that you don't have to be admitted into a system of some kind to be able to start a longer process of an inpatient or some other type of admission. And so it really does that. And I don't know if you've heard these stories, and I know we have stories coming up in the future, but there were some places that were saying they basically would let people stay for 23 hours, make them go outside for so many minutes, and then let them start their 23 over again. I think that kind of goes around what they're trying to accomplish, but I kind of get it if there's not options for people. Another one, there's two levels, right? There's crisis stabilization. You can do that in a residential setting or in the community setting. So Jason, you want to try to decide what those two kind of things are?
Yeah, so that's really short-term residential, right? It's a short-term unit that you can go to, or if you need to be somewhere 5 to 6 days, have psychiatric support, nurses on hand, have some groups. It's really a great step down from the hospital. So, as we think about the continuum of care, and this is something that's really on my mind right now because I'm working on continuum of cares in a couple of states right now, and kind of identifying that everyone does it a little bit differently. And
Mm-hmm.
so even within states, it's done differently in different regions or districts or whatever you have. And so it's important to think about that there's some things that are diversionary and alternatives, which are
Mm-hmm.
step downs, and there's some things that happen after you've been hospitalized that you
Mm-hmm.
step down to. And so, historically, subacute is a level of care that's generally after an acute care stay. It's a
Mm-hmm.
step down, where crisis stabilization would be kind of the opposite of that. It's an alternative when you don't quite need to be hospitalized, but you need somewhere that's more structured and has other people around, professionals on hand, where you can get some treatment to meet your need at that time for a short duration of time to stabilize you and then get you back to your home community.
Right. And one of the things that when you think about crisis, if this is still a rule, if there's a domestic altercation at somebody's house, somebody has to leave and they have to go
Mm-hmm.
somewhere. That could be a perfect example of a crisis situation where they need a temporary, whether that's a sit stand for the 23, or if
Mm-hmm.
it's an actual overnight situation where they need a couple of days to get a different housing arrangement, or if it's even just a couple of days to get the situation cooled off to return back. And so you don't have to think about it just being full blown mental health, big type of things. It doesn't have to be that, because the other key piece of this is you have to be stable enough to not need to be in a hospital. So if you are to the point of crisis where you have to need an emergency department type assessment, that's where you go. So if you're not safe enough for yourself or others, that's automatically determined at the beginning, and then you would be moved off into a hospital. And so it really kind of is like you're saying, it's that below that emergency level of care where you can't really be just at home, or you can't be home completely by yourself, which is the community-based side of the stabilization, where you may be able to stay home but with supports. Or you just don't need to go to the hospital, because if you need to be in the hospital, that's where you have to go, and that's awesome. But we've also found, and I know through your time and your work as well, way too many people are going to the emergency department when there probably could have been a different level of care available to them. And so one of the other levels of care we're going to dive into in our next podcast a lot more is access centers, which were specifically created for that exact issue as an alternative for emergency departments, so people could go get that emergency evaluation, if you will, and get stabilized in a different location so that they're not sitting in an emergency department. It goes back to your original story, right? You were talking about when you did the work, you would take somebody to an emergency department. It could be 3 days before they could get what you needed, and all those shift changes. That still is happening today. And so the idea of the access center, which we'll talk about more, really was the idea of how do we help people get the evaluation faster, and then maybe if they don't really need that sit in the ED for days, the situation, we get them services quicker. So on this, Jason, you've got some data that you'd like to talk about, like Where do we see where the guidelines are? Where did you find good guidelines and kind of best practices? Where did you find that when you were looking at kind of preparing for today's podcast?
Not just preparing for today's podcast, but I think about doing fidelity, right? So I've been measuring fidelity of mobile crisis teams, for the better part of 3 years and looking at are they effective? What does the data tell us? And one of the best resources I've come across that I would guide everyone to is crisisnow.com. There are so many resources buried in Crisis Now, where you can look at toolkits. You can kind of see how should this system be designed in your local community. And probably the most exciting part of it, I was actually playing with it while I was prepping for this show, is the Crisis Now calculator, right? You can
Hmm.
calculate in your community. It actually drills down to your state and
Hmm.
your county, and you can actually calculate how much savings you can bring to your local system and community if you have a full-fledged crisis continuum, right? Because
Right.
it's looking at how many beds do you need in your inpatient hospital for the population of the county you live in. And it tells you, what type of crisis center should you have? How many crisis stabilization beds do you need? And if you had this many beds, how many people could that keep out of that really high level acute care hospital? And so it really helps to guide you to think about, do we have what we need in our local community? Do we have what we need across the state, or is it too far to travel? And so it's a great starting place, and you can put numbers in and adjust that and kind of see how can you get the most value in your local area. And so I think those types of tools I think are most useful if we're looking at advocating or making policy decisions, basing it in data. And you can dig down it. If you go to the bottom of the page, it'll tell you, where do we get our data from? How are we calculating this? So you can go and
Hmm.
dig deeper if you really want to. But for me, Renee, I think that's the greatest tool that I've run across. And so I would guide everyone to go there and look at your own community, put some numbers in and see what it looks like. And ask yourself, do I have the access to these best practice tools across the crisis continuum? And if you don't know, then maybe you need to get out and check that out in your local community.
Yeah. That's really great because it's always we get a lot of questions. I know all the time on, do we have enough beds? We talk about that all the time. That's been some previous podcasts we just did this last month. And do we have enough beds? It's not always enough beds, but the right beds, the certain kind of beds, all the things. And so to have some tools out there where you can actually plug in some real numbers and look at, okay, here's what we have, here's what we need. That's awesome that you found some of those and can share them with our audience, because I know people are always out there looking. Another piece of data that we looked at was related to 988, and we've talked about this in previous podcasts as well. But the percentage of people that started calling the hotline after 988 went live, when they didn't really do a hard rollout, they did a sort of a soft rollout because they knew it would be popular. They knew that it could be a lot of people. They knew that they weren't sure. They wanted to make sure the system could hold it, that the system could do it before they just started going full bore, in as far as advertising and such. And that soft rollout, I mean, the numbers jumped significantly pretty quickly. And again, to your point, 97% of them did not need a mobile response, but the number of people who needed to talk clearly was a pent up demand and clearly met a need that we weren't really meeting. And so it's really great to see that it's being used well. And I know the data in our state, it's it's really fast. Within 7 to 10 seconds of a call that it's answered by an Iowan, like most of the time, even considering overnight 24/7. We've got a couple call centers in our state that do national hotlines for lots of people. And so we really do get people served very quickly. And they're also finding that it's pretty easy to get them then transferred to the right community to find resources. And that hasn't been as difficult as a lot of us thought. So do you have any other thoughts on 988 and some of the data you've seen out there?
Yeah, I was just going to comment, that all the call centers are connected. So there's like, what, 26 call centers, I believe, don't quote me on that, who are all connected. So your call is always going to get answered, no matter what. I think one limitation, you talk about local communities, local states answering from their own state. That's not always possible. And also the way the calls are routed is based on your area code. And area codes don't mean what they used to mean.
That's right.
Area codes now go with you, whether, wherever you lived on your cell phones. And as we see a continued decline in landlines, I think we're going to probably move toward more geolocated type call routing systems. And those are very expensive, but certainly that's on the horizon. 911 is now a geolocated system, right? So it doesn't matter what your area code is. It's going to matter on what cell phone tower you're calling from. I know that's a lot of detail, but that's important. If someone's calling an emotional crisis, sometimes that call center needs to know where that person is or needs to kind of track that back. And so thinking about the technology it takes to keep up, and keep people safe can be really challenging.
Yeah, I'm exactly one of those people. I never changed my number since I was an elected official 12 years ago now. And I live 2 hours away from that community or even where that cell phone number is from. Right. So if you were to just do it by my cell number, I'd get resources that aren't even close. So you're right. I'm an exact example of that. And all the time we have people that have moved to our community. I know like the governor's legal counsel came from New Mexico. He kept his New Mexico number, and if he gets resources in New Mexico, that's not going to help him so much when he's living in Des Moines. So to your point, there's going to have to be some, and this is where that investment in technology and when they start talking about putting surcharges and different things on things to pay for things, it's not, a lot of people don't think about all of the equipment and the wires. I will never forget this conversation. It's a little off topic, but with cell phones, people don't think there's any wires. Everybody always talks about wireless. But people realize, right, there's actual wires in the ground that support, quote, wireless, and those actually have to have maintenance and upkeep. And so it's not as wireless as people think it is. And so they just think somehow it's all just through the air magic. And that's not the thing. There's still a whole lot of wires involved. And that's just very simple explanation. But there's tons of technology related to making sure wireless calls go through. And so this is a really exciting area, and the 988 has just begun, and we know it's going to just grow and be better and better as we move forward, and just really hoping and watching for it to be more connected to all those other parts of the system, because it started with the three-legged stool. You've added your fourth leg that you'd like to see, but it'd be really cool as it develops out to really connect then mobile crisis to the places that people can go, and connect the people where they can go to the next thing, and kind of get people kind of that full continuum in a one-stop shop would be real cool. So it's really neat to see. So Jason, as you're working around the Midwest, I'm sure you've seen some challenges in some of these. So let's talk some stories for a sec. What are some of the challenges that you've noticed when you're working with mobile response in rural communities? What do we see pretty common out there?
Yeah, this is kind of where we have to keep positive, right? That it's a new system and we got to figure out how do we make new connections. And so, I think it's that relationship between law enforcement and mobile crisis response that has been some of the most difficult relationships to sort out, because it means everyone has to think a little differently. And so I come at this from a very different perspective, because I learned through my first jobs going to grad school that it was a partnership. Like that there wasn't a way to do it. It's not this or them, it's a partnership. And so we still have, and we've had strained relationships over time with law enforcement and behavioral health. And some of that is rooted, in tragedies that have happened that haven't been managed as well as they could. And so, I think a mobile response system has to sort out in local communities. What does that partnership look like? Safety needs to be paramount. Safety of the mobile crisis team,
Yes.
and that safety comes from law enforcement. And so many times, an emotional call will go to 911, right? A mental health crisis will go through the 911 system, and understanding how can 911 reroute that to 988 is one example that happens in some areas, or looking at how do we better partner with law enforcement and have co-responses. In Iowa, we have co-responder teams that actually has civilians working alongside, right along with an officer who's CIT trained, which is crisis intervention training. Many departments train many of their officers in CIT, and those cars or those units then are designed to take on a bulk of those complicated cases, because not everyone should respond to a mental health crisis, right? It takes special training, it takes the right attitude. Everyone's not cut out for that, right? And there's some days that I can tell you, when I was a mobile crisis responder, there were some calls I wasn't cut out for. I'm like, you know what, I need to sit this one out because it's just too intense, or it's just not my day to be able to do this for the next 6 hours. And you have to be able to do that and have those partners with you can trust to do that. And so, I think that's been really hard, because that really then leads to kind of my second point, which is response times. Mobile crisis teams as civilians will never have the response time of a 911 call who has dedicated radio dispatch, to be able to get somewhere. And so I think that's been a challenge as we've stayed in separate systems. And so until we get to an integration of figuring that out, I know, Renee, you just sent me an article. I think it was from Montana, and it talked about integration of behavioral health with mobile crisis teams. And they actually went to a system where they were on the same radio system as law enforcement. And the mobile crisis team would actually monitor that radio chatter. And when they heard a name of someone that they knew could be a mobile crisis response or someone having emotional condition, they would start toward the location.
Nice.
And what they found was they cut response times by like 30 minutes because they would already be en route or they'd be sitting around the corner. And so when law enforcement called them, they'd just pull up and go, we're here. And what I hear in Iowa is that's the biggest problem is it takes them too long to get here. And so law enforcement's on scene. It takes too long to get there. And so then law enforcement doesn't utilize mobile crisis and they manage some of those things on their own. And so I think that's our challenge.
I wasn't in mobile response because it wasn't the thing when I did family work back in Cedar Rapids years ago. But I'll never forget more than one time challenges with certain families I was with. And the family would call, or somebody called 911, but somebody also in the group would call their therapist. And I was the therapist at the time. And I would roll up to some interesting situations. One time I had a kid on a roof, right? Cops are there trying to get a kid off a roof. And somebody, I don't know, family member, somebody are like, we're calling this therapist. And I get there and then they're like, oh my gosh, thank gosh you're here. Let's go. And I could get the kid down and do the things, but I wasn't even really my job to be a mobile response, but the family had said, can you come? And so I know just by having lived it and worked it and done it, I've done it on my personal life side of people call me in an emergency because they know who I am and what I do. Could you come and do? And yes, the answer is yes. So to have it where it's more connected is going to be awesome. And I'm excited to hear about that. But, it is challenging to your point about, people are passionate about this. And so I don't know that it's, again, a cookie cutter approach. You can't just say, so no, there's the folks that are kind of more trained on the crisis side that are lay people from the law enforcement perspective who want to just do this with no law enforcement, no uniforms, no cars with lights. I'm telling you what, there's some scary people that call for crisis. And I might be more comfortable as the therapist showing up on the place with law enforcement with me. Right. And so it's not an all or nothing. It has to be a partnership. And that scares law enforcement because they're like, man, we're not going to send people that are not armed, not trained, as crisis counselors, they're like, bless your hearts. We're not sending you in some of these places without law enforcement. And so you've got to see both sides. Everybody wants people to be safe, but there's all these opinions about how that should happen. And to your point, it has to be a candid conversation, communication, collaborative, and figure out what works for them in their community. It's not going to be the same everywhere. And so, as we continue to work through this in our state, we're really hoping that they give some people some flexibility because we have 4 pretty interesting options, some with ambulance, some with first responders, some with, law enforcement, and some just without, and it's just trained crisis specialists. And, having that blend so far works for those different communities. So it'll be interesting to see how that goes. Another story, Jason, is about access centers. And we're going to dive deeper into that next time about what they are and what they do. But talk a little bit about, in your opinion, what were they for? And what's the point? And why would we want to do a deeper dive into this next time?
Yeah, and I'm kind of fluid on access centers right now. There's so much going on in several states around this issue, and so I'm kind of going back and forth, right? So let's make it simple, right? Access centers to me is the same thing as a fast track medical clinic, right? It's a place where you can go, that it's not emergent, but you need to talk to somebody right now, right? And so it's not like you can just call your primary care physician and get in for an appointment. It might be 6 o'clock at night. But, fast track or urgent care is open. And so if the urgent care clinic is there and has extended hours and I can go and meet with a professional and they can help to ameliorate my immediate need, then that's the place I want to go. And so really that's the principle of an access center, right? Kind of boil it down. It's an access point that should speed up your ability to access the system and get to where you need to get your needs met to manage the crisis you're presenting for.
Right.
The issue is in rural areas, it doesn't really work out because your access center could be 60 or 70 miles away, and that may not be something you may not have access to a car to get that far. It may be difficult to travel. So access centers are really difficult if you think about them as a physical location, and so we've worked on some projects where we're piloting, some virtual access centers where we're creating a no wrong door approach, right? That no matter where you go across the provider network, whether it's their specialty or not, they can help to give you a warm handoff and get someone who's presenting maybe in the wrong place, get them to the right place and make sure they don't fall between the cracks. And so that's taking the spirit of access centers and spreading it across a virtual network. And so I think there's a lot to be said about that as we look forward. We're still in the middle of working through some of the details of how do we create policies and procedures that say 12 organizations across the 12 county area are going to adhere to, and train all of their staff so that we're actually connecting people and doing warm handoffs and sitting with someone who needs that.
Yeah, I'm looking forward to the deeper dive on this topic, because access centers really are an interesting piece, because it's not the continuum of crisis itself, but it can be one of the front doors, just like a 988 call. So it's kind of like, to me, another kind of a front door like a 988, but instead of call, text, or chat, you get to maybe go through a door, a physical door, or even to a provider and say, hey, I need help. And I know for myself, if your analogy of it being like a medical clinic is really spot on, because there's times where I'm like, I'm not sure. I don't feel really good. I don't think I can wait till I could get into my regular doctor. I probably ought to get this checked out. You don't wait until, if you're to the point where you're really, really sick, they're going to make you go straight to the emergency room, right? So it's kind of that in between. It's like, I'm not sick enough for the emergency department. They're not going to admit me today, but I am not also well enough to wait to get in. So I need something sooner. And sometimes that's just to help you have maybe something just in that moment to calm you down, to like deal with the issue in that space. And an access center in that concept is a really smart idea. Did you have any other thoughts on access centers this week, or you want to save it for the next podcast?
We're going to say, I'll just give you a little preview, right? We're also going to talk about CCBHCs, because they may be our new access centers. And so maybe access centers aren't something we need, but then we also have to think about in rural areas, what about our critical access hospitals? Are they not an access center? And so those are some struggles. And that's what we're going to really dive deep into, is looking at where do people go now, and is it the right place, and are they prepared to handle what they're being presented with?
Yeah, lots more to talk about. So this week, we're going to talk about a recovering politician self-care policy. And this one's a little bit different. I'm thinking about, we came across out of spring break, kind of is right now across our state and across a lot of other states. It's sort of this middle of March. Everybody's like spring break from school. And if you have kids in school, you think about spring break. If you don't have kids like me, you don't think about spring break. You can go on vacation whenever you want. So it's different. But what is true about this time of year is starting to get a little bit warmer, a little bit sunnier. And so I'm thinking about summertime activities. And now is the time when activities that I enjoy come open for registration for things. And so, as a lot of you know, I have a recumbent trike named Rhonda, because she helps me up the hills. And anyway, Rhonda and I spend a lot of time on a bike, and we do a lot of bike activities. And so there's like weekend trips and, distance rides, different things. And so for me, this time of year, I get kind of excited. I'm kind of plotting out my summer and into the fall of how many bike trips do I want to do, or if there's special events that come up at my gym. They always have these special all kinds of interesting things that they do, like a pool parties or different things. And they start putting things on the calendar now as kind of a, hey, only a couple more months of terrible weather and we're going to be able to do something fun. And so for me, it just gives me that extra boost of hope that, hey, winter is not forever. Spring is actually right around the corner as far as the date's concerned. So I better start booking stuff now. So Jason, have you had any thoughts yet? Have you got fun plans for summer? I know you've got that boat. Are you getting ready to pull it out and ready to think about what's next?
Oh, I haven't even thought about that. No, but I should be, shouldn't I? No, this has we've kind of been on a concert binge. So my wife and I have been going to different concerts. And so we just booked, there's going to be an outdoor concert in Minneapolis coming up this summer, a 2-day, where we're going to see Gwen Stefani, Alanis Morissette, the Black Crowes, Joan Jett, the Red Hot Chili Peppers, Offspring, Soul Asylum. So we're going to be along the river somewhere in Minneapolis. So that's in July, right? And so we booked that, and it was kind of one of those, just like you said, something to look forward to, right? Something kind of it certainly dates me, right? Like of what era that
Alanis
we're going to go
Morissette
check
right there
out.
told you all we need to know.
I know, pretty much.
Well, it's you and the mosquitoes, so I'm looking forward to hearing all about it in Minnesota in July. That
That's right.
one month of mosquitoes right there. Well, this week, everybody, we just to review what we went through today, we talked about that big picture of what should a crisis service array look like. And to be excited, we have a lot of pieces of this that actually do work. They're great. It's not everywhere yet, but it is getting better. And the 988 system fit nicely into this continuum as a big access point for kicking off. How do you get into a crisis system? And it just can only get better from here. And Jason shared with you a nice tool with crisisnow.com. If you want to look up to see if you've got the crisis services that you need, be sure to check that out in the show notes and look at that and see what you need. And if you don't, that may be time to have one of those candid conversations with someone about how you too can get the services that you think that your family deserves where you live. And so next time we're going to do a deeper dive into more of these crisis services, including access centers. See you then, everybody.